What I thought in terms of a update for the Cochlear Center is to actually give you a basic overview of a strategic vision which we've developed over the past year. As probably similar to all of you, we've all had a bit of a reset this year in terms of actually having some breathing room to be a little more introspective about our time and what we want to focus on. For the center in particular, it served as a unique time point. We are 3 years now into the Cochlear Center. And the last year, having to essentially stop a lot of our travel, stop a lot of our events, it's given us some time to think more deeply about what we want to try to accomplish as a center and what we're trying to do. So what I thought I'd do over the next 15 minutes is to give you sort of an overview of what's come out of it. And that will give you sort of a perspective on what the Cochlear Center is doing now and what we hope to do in the future. So we start with some foundational principles. These are some, I would say, bedrock principles that underlie what we're trying to do as a center, which we've really come up with over the last year that serves to guide us in terms of everything we do. And the first one's pretty intuitive. It's the idea that for any one of us, we fundamentally believe that our ability to hear and engage with others and the environment around us is absolutely foundational to healthy and successful aging. Namely, our ability to interact and to engage allows us to do everything we want to do, particularly in later life. And this seems like a common sense idea, but it undergirds almost everything we do and why we're doing these things at the center. The second thing then is that we recognize that the widespread prevalence of hearing loss in older adults, it's not going away. Research into preventive strategies, let's say noise reduction, and or in the future, hopefully neurorestorative therapies are all needed, but we sort of know deep down that this is no way a panacea. Right now in the United States, 2/3, or actually around the world, 2/3 of everyone over 70 has a hearing loss. And I think probably many of us realize this problem is not going to go away. We can try reducing it. We can try in future having restorative therapies, but virtually hearing loss is fundamentally tied with the aging of the inner ear, which is fundamentally tied to aging biology, which will be likely never fully reversible. So this problem is with us to stay for a while. With that in mind, then, a third premise of what we begin with then is that the Cochlear Center fundamentally is a little different from other sort of hearing research centers, is we're focusing on what can be done now, specifically across 5 core areas to really address hearing loss in older adults at scale, right? And that's the issue at scale, given that 2/3 everyone over 70 has a hearing loss. And we hope to do this fundamentally through what we consider transformative public health strategies. So it's not the typical research we think about in the auditory sciences, but using public health research methodologies, as well as a public health lens to aim for transformative strategies to address this problem at scale. And we fundamentally focus on 5 different areas. There's population health evidence, there's public awareness, there's actually individual care treatment models, healthcare policy, and finally, actual hearing technology to some extent as well. Now, the fourth foundational principle then is that fundamentally our mission as a center then is to really educate and train a generation of clinicians and researchers around the world who can really begin thinking about hearing loss in older adults from this public health perspective and through this public health lens to enact these transformative policies. Now, with that in mind, when we think about addressing hearing loss in older adults at scale, we fundamentally revolve around these 5 core areas where we realize over the past years, we've been giving more thought to this, that almost everything we do now as a center can really be thrown into one of these different buckets. And we're hoping to unify us a little more in terms of orienting everything we're trying to do as a center. So I'm going to take you through these briefly, give you an overview and survey of what we're doing and what we're hoping to do in the future. So it begins clearly with population health evidence. This is the bedrock principle foundation from which everything else flows. Without evidence, a robust public health evidence, nothing else really matters when we think about addressing sort of hearing loss. To that mind, our fundamental strategy here around this core area is that we really need to develop robust population health evidence on hearing loss through both center-led research and, more importantly, through encouraging and facilitating inclusion of hearing into other population health studies. So the initiatives here, clearly one thing we've been doing for many years, led by Jennifer Deal, Amber Willing, Nick Reed, Carrie Neiman, others in the group, is really carrying out our own epidemiologic and health economic studies, laying out the foundation for how and why hearing may matter in the grander scheme of public health. So that's clearly one core area, so ongoing. A second big area for us and one of our sort of pinnacle landmark studies that we lead as a center around the United States is the ACHIEVE trial. So a actual randomized controlled trial determining and providing definitive causal evidence of what happens when we treat hearing loss. And finally, an equally important thing then is how then do we begin encouraging integration and inclusion of hearing into other much larger studies as well. Many of these studies have been going on for years that directly inform and influence health policy, but they have never, or maybe never have, or never really formally considered the role of hearing into their analyses, mainly because hearing measures haven't been available. So to this end, one key thing I mentioned before is the ACHIEVE trial. This is a randomized trial funded by the National Institute on Aging. It involves nearly 1,000 older adults who have been randomized through October 2019 to receive either hearing intervention or basically a control intervention. And this trial, when it's finished in 2023, will establish if treating hearing loss in older adults can actually reduce the risk of things like cognitive decline, dementia, falls, and healthcare costs. So you can imagine when this trial comes out, again, it might be a transformative change in terms of how we can begin thinking about societally about the role of hearing care. At the same time, though, I think epidemiologic evidence and clinical trials are great, but we need more of it, right? So one big thing here is integration of hearing into these much larger studies, which have heretofore not really considered hearing. So these little pictures here are just a small, actually, smattering of the studies now that the Cochlear Center, mainly through the work of Nick Reed and the Audiology Corps, now directly focused on overseas hearing integration into these studies. The atherosclerosis risk and community studies, and called NHATs, just you can see them down below. Impressively, by the end of 2021, what that means over the last 5 years then is a center will have overseen over nearly 30,000 unique hearing tests among participants in these data sets alone, and those only accelerate going forward. And I think this is key because this allows researchers around the world who may be interested in hearing to begin incorporating these measures into thinking about how they understand their outcomes. Now, beyond population health evidence, I think one key thing, which probably all of us recognize, is public awareness. How do we translate this evidence actually into actually different policies, and how do people become aware of it? Our tack here is actually sort of new. We have actually never focused directly on public awareness before. So in the last year, we've just begun in a new initiative, which is just currently under planning right now, where our tack on how to build public awareness may seem a little unconventional, but what we're hoping to do here more than anything else is to establish a common language and a common metric then for beginning to understand and discuss hearing loss. So what I mean by this is something specific. We're launching something called the Know Your PTA initiative, or Know Your Pure Tone Average, which again is derived from the audiogram, which is a measure of hearing. And I'll talk a little more about this in the next slide as well, but it's something we're just beginning now over the last year. It's our first sort of toe dip into the water of how to build a public awareness at scale. So what I mean by this is typically when we think about hearing and how we talk about hearing, we use these categories. I have a mild, or he has a moderate, or severe hearing loss. And I'll tell you from a clinical as well as a research standpoint, these categories are often somewhat meaningless and very, very stigmatizing. It's not all of a sudden one day you have a hearing loss. You've probably had it for many, many years. It's something that's just been growing for any of us as we develop, as we age. All of us lose some hearing as we age. In turn, these categories are relatively arbitrary how we classify them. Instead, though, you can imagine what happens if everyone knew instead their pure tone average. A pure tone average, again, is that derived from the audiogram. It fundamentally represents essentially how loud speech sounds have to be for you to hear them, right? So it's roughly convenient the number between 0 and 100, 0 decibels being very, very soft, 100 being very, very loud. It represents how loud sounds have to be for you to hear them. That pure tone average already is the basis for how we classify hearing, but rather than talking about hearing with the actual number, we apply these somewhat arbitrary categories. Importantly, when you go to a number that all of us can recognize, much like, for example, I need glasses, but I recognize what my general prescription is. I'm a -8. I'm actually pretty bad. Or if you have diabetes, you roughly recognize what your blood sugar is, or you might know your height. The same metrics. No one knows their metric when it comes to hearing. But when you do have a metric, it changes the dynamic for what you communicate and know about hearing. For patients, you can finally understand your hearing in quantifiable terms without stigma. For example, your PTA may be a 24 or 25. Doesn't necessarily mean you have hearing loss, it just means how loud sounds are for you to hear them. So it destigmatizes and automatically you recognize what that number means to you. Last year you're 20, now you're 28. That actually is a significant change, but you begin recognizing that rather than understand that you're in the mild hearing loss category, for instance. For hearing clinicians, for me, for instance, when I'm talking to patients about their hearing, I can anchor against number. Immediately when I see a patient, I know what that number means, and I start anchoring against as I discuss treatment options. For primary care doctors who normally get this really long report from an audiologist or ENT that is sort of difficult to interpret, they can start anchoring that PTA against knowing their patient's communication needs. If I see someone with a PTA of 40, which is on the cusp of moderate hearing loss, I automatically recognize that I probably need to make face-to-face communication with them. Likewise, for primary care doctors, PTA is the main basis for which we conduct epidemiologic analyses. If you want to inform patients about, quote unquote, their risk for things like dementia or other outcomes, you need to know their PTA. And finally, for industry, whether it's a consumer tech industry or it's a traditional hearing industry, fundamentally a consumer base that understands their hearing opens tremendous opportunities to better communicate what those companies are trying to do. Now, importantly, we are at a convergence point right now. In the top right there, that is actually a screen grab from my iPhone. The latest generation of the iOS for iPhones, for many of you may not realize, you can actually go in right now and plug in your AirPods. Actually, hopefully don't do it now during this webinar, but you can actually measure your pure tone audiogram. Mine actually, fortunately, is still pretty good. I'm a 12 in my left ear, right in my 10 ear. That is something that's baked into every single iPhone nowadays on the market. With your compatible headphones, you can calculate your pure tone average. So the means are there now to make this scalable. So again, this is an initiative we're just beginning now. We're launching right now. We're trying to identify a communications agency partner to partner with over the next year, as well as building the collaborative partners across industry, academia, and advocacy groups to launch this going forward. Importantly, though, it goes beyond public awareness. We also need care models. One huge issue you can imagine with how do we actually address hearing loss at scale if so many people have hearing loss. There are not enough audiologists and ENTs out there to treat everybody. So our fundamental strategy here is on how do we begin developing and testing and disseminating new models of care, particularly those focused on task sharing, expanding beyond the traditional clinicians who deliver hearing care. Two of our major initiatives there led the HEARS model led by Carrie Neiman and the ENHANCE model led by Nick Reed, focused very much on this expansion of the workforce and task sharing to allow for different models of care. I'll highlight each of these briefly. The HEARS model is fundamentally a first-in-kind approach toward delivering accessible and affordable hearing care in the community using community healthcare workers under the auspices of a clinician team to deliver care directly in a senior center, directly in someone's home, directly in someone's church, using off-the-shelf, over-the-counter technologies, as well as other screening methods to allow for a rapidly adoptable method of care. You can already see with this, for example, the right there, that's one of our promotional brochures to promote the HEARS program. We're focused very much on delivery in the community with a community healthcare worker, as opposed to medicalizing the model. And this allows for a much more scalable approach, potentially how we deliver and address hearing care in a much more culturally competent way than our traditional clinician-based models. At the same time, something called the ENHANCE model. This is a little different too. In the hospital setting, where many patients in the hospital have hearing loss just by virtue of age, how do we address communication there and needs there, when we're increasingly understanding the impact that hearing loss can have on things like 30-day rehospitalization rates, and possibly even the rates of delirium? How do we address hearing in those settings to optimize patient-provider communication? It can't be just, get a hearing aid. It's not scalable in a market like that. Through Dr. Reed's efforts using called the ENHANCE model, integrating hearing care and addressing hearing care needs directly into the nursing workflow without even the need for an audiologist or an ENT. And these are some of the materials there in the pilot studies I've been using to frame this out, to implement it and see what effect it has on these much larger outcomes, such as length of stay and 30-day rehospitalization. That's ongoing right now as well. At the same time, the hallmark of everything we try to do is ultimately influence policy. We realized in the end to make, if we really want to address hearing care at scale, you either have to make a financial business model for it, or it has to be baked into policy so it's sustainable at scale. One of the main things we've been doing there over the last several years then is, as best as we can, is trying to be the go-to resource for decision makers, policymakers in Congress and elsewhere when it comes to things around hearing care and funding policy. One of our main avenues there through which we work is through disseminating, whenever asked, to provide policy briefs or memos directly to congressional representatives or elsewhere to educate policymakers about the issues around hearing care. Most recently, over the last year, we've been launching a series of policy briefs. This is just one of them here, which goes over specifically for Medicare, namely the tagline, effective legislative proposals for Medicare are essential, or the hearing care services are essential, but hearing aids may be in fact be optional. Hearing care rehabilitatives are critical. When hearing aids possibly and do go over the counter, it can be split costs. It doesn't have to be a one bundled cost. We cover the services through the insurance side, but patients actually buy, for example, their own Samsung or Bose hearing aids. To To this end, one key memo that was prepared by Amber Willings, one of our core faculty, directly to the Ways and Means Committee about a year and a half ago now, served as a direct basis for House Resolution 4618, which then got passed in the law, which got passed by the House of Representatives as HR 3 in December of 2019. And that bill, if eventually written into law, would essentially have Medicare for the first time ever fully cover hearing rehabilitative services for all older adults. Hearing aids will be covered if you have more of a severe hearing loss. Otherwise, hearing aids you buy yourself. We see that sort of best fit model as a model going forward, where it shares the risks and the benefits of hearing care across from the government as well as the providers, while allowing consumer technologies to float on the free market to allow for cost effectiveness and cost savings when it comes to the hearing technology side of things. This is an ongoing process. We think it's unlikely this bill is likely to be advanced further this year, given competing interests in Congress, obviously. But we do think in the next 2 or 3 years, with the passage of the Achieve trial, that there may again be a very, very clear window to advance Medicare legislation. Again, the main way to do this is through directly informing and engaging policymakers whenever we can around these issues. The last thing I'll touch on is even hearing technology. We are not a traditional hearing research shop. We actually don't directly do like research with hearing technologies like other groups do in terms of designing technologies, but we do try to get involved. And more importantly, our strategy here though is to fundamentally champion hearing technologies that incorporate universal design. So what do I mean by universal design? I fundamentally by universal design I mean things that are equitable. So basically it's useful to many different people across many different abilities, that it's flexible, namely it can accommodate the individual needs of different users. And finally, that it's simple and intuitive and can be used at scale in many different settings. We think the way to get there, and one of our big wins several years ago now, was getting federal law passed around the Over-the-Counter Hearing Aid Act, which when enacted should have gone into effect last year. It's been delayed because of COVID. But when it does go into effect, this is what allows companies like Samsung, Bose, any company to manufacture hearing aids and meet some performance standards to be directly available to the public. And we think that opens up the door very, very quickly then for universal design when it comes to hearing technologies. For example, I have Apple AirPods right now. Are these Apple AirPods or are they hearing aids, right? In the future, it'll be indistinguishable and it'll be seamless across the ecosystem in terms of how we think about hearing and how we think about communication. Another thing which we have not had a direct role in, but we follow very, very closely with some of the key people in the field in the Bluetooth group and elsewhere, is the role of Bluetooth LE audio standards. It sounds very esoteric, but this gets at the hallmark of universal design. The next generation of Bluetooth announced 1 year ago today now, and we've rolled over the next 3 years. For the first time, will allow Bluetooth allow for broadcast sound transmission. What that functionally means then, with any pair of compatible Bluetooth devices, you go into any theater, any lecture hall, any airport, and you'll be able to hit a button, you'll be able to tune right into the sound stage. You'll be able to tune into the overhead monitors. You'll be able to listen to the TV in the waiting room. You'll be able to hear the announcements. So you can imagine that's a quintessential aspect of universal design. It doesn't matter if you have a hearing loss or not, but that becomes useful for everyday life. So we're a huge fan of the Bluetooth LE audio standards, and we're very, very closely following the rollout over the next several years. Well, we do feel that is a game changer for the field about what can happen going forward for hearing technology. So that's a little bit of a wrap. That's fundamentally how we view and how to potentially transform the issue around hearing care and public health at scale is fundamentally through each of these 5 different areas. Now, I want to say now at this point then where I'm really, really thrilled to introduce our keynote speaker here, Bret Rutherford. So Dr. Rutherford did his medical degree and psychiatry residency at Columbia University. And he's been on the faculty at Columbia since I believe it's about 2009 now. His research is fundamentally the intersection of, I would say, neurobiology, especially neurobiological mechanisms, and late life psychopathology, including late life depression and dementia. And actually, I think I met Dr. Rutherford for the first time several years ago now after reading what I consider arguably one of the best reviews in the field right now for relatively a niche area around hearing and cognition and dementia. But it was a review he authored in the American Journal of Psychiatry, I believe in 2018, maybe 2019, which is really an incredible review that offered new insights, new ideas on how to think about this relationship. We had Bret scheduled to be in person with us last year. We always had to delay that because of COVID. Never in our minds do we think that we have to delay it in-person meeting again this year. But we're absolutely thrilled, Bret, that you could join us at least virtually for today. And we are very much looking forward to your talk. Again, for the audience, please, if you have any questions during Dr. Rutherford's talk, please use the chat box. And at the very end, we'll have a moderated Q&A with Dr. Rutherford at the end. But without further ado, Bret, I'm going to stop sharing my slides now. I invite you to share your own, and we're excited. I'm really excited to hear your talk. Thanks again.
Great. Thank you so much, Frank. I'll just... Great. Hopefully you can see my screen now. Good. Well, thank you. It's really a pleasure to be with you virtually. I'm sorry that we can't be meeting in person, and what an inspiring review and introduction to all you're doing in the Cochlear Center. So congratulations, and thank you for leading the field on that. I'll be talking about perhaps less broad in scope, but hopefully just good in its own way. Research on addressing hearing loss to improve mood disorders and neurocognitive health in later life. My only disclosure is that Phonak, a hearing aid company, has generously provided a number of hearing aids for some of our treatment studies, but no other disclosures, no discussion of off-label medication. And as Frank said, I'm a psychiatrist. I'm a researcher at Columbia. I study depression and aging. And so my talk today has 4 parts. I'd like to tell you a little bit about late life depression and how we're approaching that in my lab. And, or in other words, how I came to be interested in hearing and get into this world a little bit. Then I'll go on to describe some of the work we've done, linking hearing loss more systematically to diagnosis with late life depression. And leading into what really is our focus is drilling down into the brain mechanisms linking hearing loss to depression, which we hope will, through the identification of these mechanisms, will give us a leg up on what to do treatment-wise for these patients. And then I'd like to tell you about some of the initial studies we're doing to determine whether treating hearing loss is therapeutic for late life depression. And I hope it's okay in that I'm excited to be here and speak with you all and look forward to our discussion. I'll be discussing some things that are published and out there, but I really also wanted to give you a sweep of the kinds of things we're doing in our lab. So some of it is going to be hot off the presses and not yet published, but I'll be interested in getting your responses too. So to begin, for those who may not be as in the depression world as I and my colleagues, late life depression, when I say that, I mean depression of various stripes in people over 60. It's actually quite a prevalent disorder, which may not be immediately appreciable when you look at large epidemiologic surveys like the National Comorbidity Survey replication. Generally, when you see these big epidemiologic studies, they give yearly prevalence rates for depression in people over 60 in the 4 to 6% range. And as I'll go on to share with you, that may be a bit of an underestimate, given that the types of symptoms people have when they're older change compared to younger adults. And so some of the ways we have of ascertaining when somebody's depressed are not as reliable, as our diagnostic criteria in psychiatry are not age adjusted. Another thing is that, I'm just going to hide that. There's a lot of sub-threshold symptomatology in older adults that we consider to be very clinically significant. So there, anywhere from, if you look at here on the right-hand side, if you look at just a measure of depressive symptoms, not necessarily meeting full criteria for syndromal major depression, and you look at age across the x-axis, symptomatology generally decreases across the lifespan until you get to your early 60s or so, when it starts to increase again. And if you look at what we refer to as clinically significant depressive symptoms, we see these in anywhere from 25% of community dwelling older adults to approaching nearly 50% for older adults in skilled nursing settings and such. So depression is actually one of the more common problems we deal with on our older adult patients. We also care about late life depression a lot because it's linked to some of our very objective outcomes in later life neuropsychiatry, one of them being dementia. Depression is one of the foremost risk factors for developing incident dementia. We believe that depression, through having negative effects on medial temporal lobe and hippocampal structures through glucocorticoid toxicity and stress hormones having a toxic effect on the brain, to links to vascular disease and little mini strokes and white matter hyperintensities on MRI scans. Essentially, depression really lowers the brain reserve and lowers the threshold for Alzheimer's disease and other neurodegenerative pathology to lead to clinical dementia. So we see depression as a very significant moderator of the development of neurodegenerative disorders. Also, depression can be lethal in older adults. I'm not sure if people are aware, but while younger individuals make more suicide attempts, it's actually older individuals, actually older white men, who are the people who succeed in killing themselves, both in the US and worldwide. The highest suicide rates that we see in anyone are in older men. So it's very important to recognize and treat late life depression by whatever means possible. Thirdly, late life depression being a very prevalent disorder among our older adults, one that can have very severe or lethal outcomes. Therefore, it's unfortunate that we don't do too good of a job in treating it. In this slide, I'm just showing that whether here you have younger people in black and older adults, people over 60 in the white columns, and we have the proportion of responders or remitters to antidepressant medication. This is just a naturalistic survey of some recent people going through our clinic. And what I'd like you to draw from this is that response rates, typically we define response as your baseline level of symptomatology getting at least 50% better. We see decreased response rates in older adults compared to younger adults, and decreased remission rates. Remission is a very clinically important notion, indicating you have basically a very low level of symptoms and you no longer meet the criteria for major depressive disorder. We've done a number of meta-analyses of antidepressants compared to placebo. And again, you see whereas in a typical placebo-controlled trial, we might see response rates from 50–60% in younger adults. These are more like 40–50% in older adults with correspondingly lower remission rates. In the best source of evidence, when we do large, rigorously designed, randomized controlled trials of antidepressant medications versus placebo, we oftentimes, like in this study done by my research mentor, Stephen Roos, we see no significant differences between drug and placebo. In fact, many of the antidepressant medications we use in older adults, there are no randomized controlled trials indicating a benefit versus placebo. In many of the medicines we use, we're simply generalizing evidence from data in younger adults to older adults. So our treatments, particularly antidepressant medications, have very limited efficacy. Not that they don't work and that they shouldn't be pursued and used, but they have serious limits. Part of the reason, and this gets a little closer to my interest in hearing loss, I think part of the reason we haven't done such a good job in treating depression in our older adults is because we have failed to appreciate the late life part of late life depression. And that until surprisingly recently, it was thought that depression is depression. If you're 25 or if you're 75, doesn't so much matter. Perhaps there are certain pharmacokinetic or pharmacodynamic differences, we need to dose the medication differently, but it's basically the same illness and we treat it in the same way. Really, since the beginning of the 1990s, when we started to understand how older adults who had depression come on later in life, how they had a lot of evidence for little mini strokes and vascular pathology, we started to understand that the causes and manifestations of late life depression can be different from depression in younger adults. And as we've expanded upon that evidence base, if we see here's my little indicator for depression in younger adults, and this Van Gogh painting, which I think nicely expresses depression in older adults, we see that the symptoms or the phenomenology of depression is very different across the lifespan. We often refer to depression in older adults as depression without sadness. Because if you ask many of my patients, are you feeling blue, sad, down in the dumps? They say, no, what are you talking about? But they have a lot of memory problems, they have pains, they have somatic issues, they don't have much energy. The pattern of presenting symptoms can be different, sometimes leading late life depression to be poorly recognized. A big difference between depression in younger adults and older adults is the great preponderance of cognitive difficulties, particularly something that we'll get into more called executive dysfunction, which is present in half or more of patients with depression over 60. As I've said, antidepressants do not work as well for older adults compared to younger adults. So the treatment response is very different between the two populations, and the course is different. Late life depression is associated with a chronic, recurrent course. Generally, if it comes on later in life, it's hard to get rid of and tends to stick around and be associated with many recurrences, whereas it's often much more easily treated in younger adults. So a take-home message from this point in the talk is that depression is not depression, that depression in older adults can have different causes, it can present differently, it can respond to different kinds of treatments. And that's really what my laboratory studies. That we studied, as Dr. Lin referred to in his introduction, this very well-known paper describing different aging processes. We study interactions between aging processes, broadly construed, and later life neuropsychiatry, things like depression. We study how changes associated with aging lead in this arrow direction to depression, how brain aging, other changes in the body associated with age can make a person more likely to develop depression, can change the way it presents, and in particular, what's going to make it better. And of course, we're also interested in this other direction, because it's true that the occurrence of psychiatric disorders, and particularly depression, across the lifespan affect the aging process, and people age less healthily when they've experienced multiple episodes of depression. So what we try to do, if this is in some ways the current state of the evidence, where if you imagine this circle contains all these different people, and we diagnose them with late life depression. And currently the standard of care is to give them antidepressant medication, which is effective for some people, but is essentially an empiric treatment that does not account for or attempt to directly address the exact route that led a person to get depressed later in life. So if you imagine these different colors represent different etiologies or causes of late life depression, antidepressants aren't necessarily dealing with any of these different causes. They're treating all of these patients the same, essentially. And what we try to do is leverage an understanding of the age-related causes of things like late life depression to say, aha, here, this person, for example, has vascular depression, and they're depressed because they had these mini strokes affecting frontostriatal white matter tracts. And what we need to do is very aggressively manage their cardiovascular risk factors and give them forms of psychotherapy that are going to help them overcome the attendant executive dysfunction that they may experience. Frailty is associated with getting depressed. So we need to do some nutritional support and exercise. Dopaminergic decline is a big interest. So, and so on. In other words, we try to understand this heterogeneity and use it to develop novel treatments and target them to the specific subgroups of depressed patients we think are going to be responsive. So it was in that context, and that's what I do, trying to really understand the situation of depression in a geriatric patient, and as part of a complex geriatric syndrome, that it was fortuitous that I was introduced by a colleague, through a colleague, to Anna Kim, who's a cochlear implant surgeon and researcher at Columbia in the Department of Otolaryngology and Head and Neck Surgery. And she started educating me about age-related hearing loss, which, as Dr. Lin said in his description of the cochlear center activities, increases dramatically across the lifespan, such that, really more than half of people over 70 to 2/3, and pretty much everybody over 80 has some form of hearing loss. And that, as I learned quickly, far from being gray hair or some quality of life issue alone, hearing loss could have major neuropsychiatric consequences. And here you see a well-known figure from a Lancet Commission report a few years ago now, where looking at various so-called modifiable risk factors for dementia. So we think that about 35% of yearly new cases of dementia are potentially preventable. The largest preventable cause of dementia is hearing loss. Depression is another big one down here, other things like physical activity and managing cardiovascular risk factors. So I started to get interested in, well, what about depression? That's a neuropsychiatric condition. That's something that's very related to dementia as well. What about hearing loss as an age-related process that could be happening in my patients that I haven't even been thinking about, I haven't been measuring? How might this be, these two entities be linked? So I'm going to describe some of our studies. First, just looking to see whether there is a connection between hearing loss and late life depression. And in a lot of what follows, I'll be really describing the hard work of a number of talented and smart young investigators working in our group, one of them being Katie Brewster here, who's done some of these studies and is doing a lot of important work in our group. In this initial study, we looked at data from the Health, Aging, and Body Composition study, which was a study of 3,000 or so functionally intact older adults aged 70 to 79 at baseline, and then they were followed for 10 years and looking at various things. This study obtained self-reported hearing data at a few different time points across the 10 years. They also did audiometric testing where they assessed pure tone thresholds at year 5 of the study, so about right here. We've looked at this data set for a few other things, and when we've done statistical modeling, we can see three trajectories of depressive symptoms in this study. Some people, here on the bottom line, start off with low depressive symptoms and stay low. Some people start with low depressive symptoms and increase. Some people start high and stay high. And when we look at these trajectories in the context of hearing data, people who have self-reported impaired or worsening hearing in this study are much more likely to have a high or increasing depression trajectory versus a low one. If you look here in this table, also pure tone threshold, the correlation between, there was a significant correlation between pure tone thresholds at low frequency and mid frequencies and depressive symptoms. The auditory thresholds for people with clinically significant depression here measured by a CESD score over 10 were significantly greater than those who did not have clinically significant depression. So hearing loss was associated on a continuous basis with depressive symptoms. And it wasn't just, you know, a point or two here, but in a non-clinically significant way, but really a clinically significant depression was more often seen in people with hearing problems. We've looked at this in other data sets, one being the National Alzheimer's Coordinating Center data set, which was 8,500 adults over 60. This was a large data set, but we narrowed it down to 8,500 people over 60 who had no mild cognitive impairment or dementia at baseline. Hearing here was determined by a clinician interview. And the clinician was asked to rate, without hearing aids, does this person have any hearing trouble? And do they wear hearing aids? So we differentiated untreated hearing loss, which was having hearing trouble and not having hearing aids, to obviously treated would be having hearing loss and wearing hearing aids. Depression was measured with the geriatric depression scale. And we did some modeling, controlling for baseline depression, essentially looking at the association between having a clinician interview saying you had treated or untreated hearing loss and what happened to depression and cognition over time. And if you look here at the top, somewhat surprisingly to us, treated hearing loss, so people who were found to have hearing loss and had hearing aids, had a significant, had a higher odds of developing depression over follow-up. This was not true for people with untreated hearing loss. Now, to get at why that might have been, when we look at dementia, the risk for dementia, patients who had hearing loss and at least the clinician said they were prescribed hearing aids, had a significantly increased odds for diagnosis with dementia over the follow-up period, which was not true for the untreated hearing loss population. Depression, which we always see, it was significantly associated with diagnosis with dementia, both at baseline, and then if depression stuck around during the follow-up period, the odds for dementia were even higher. Well, we ended up interpreting these data to, as we found it unlikely that hearing aids were toxic for cognition, we basically hypothesized that somebody with treated hearing loss had probably had more severe, longer duration hearing loss compared to the untreated population. That here treated was really a marker for severity and duration, indicating that more longer and worse hearing problems were likely more toxic in terms of depression and dementia. Justin Golub here is a K awardee who's studying hearing loss and cognition at Columbia. He looked at hearing loss and depression in non-white patients here in Hispanic adults, also showing significant links between hearing loss and depressive symptomatology. If you look here, we basically see a dose-dependent effect. As hearing category, your pure tone thresholds from over 25 being mild hearing loss, and so on, moderate to severe. That if you look in the middle here, you have CSD 10. That's our threshold. The Center for Epidemiologic Studies Depression Rating Scale score over 10 indicates significant depressive symptomatology. A score over 16 correlates highly with syndromal major depression. So as your hearing loss proceeds from no hearing loss, the reference group, to mild, moderate, and severe, you can see the odds ratios increase up to about 3 times more likely in the moderately severe or worse group to have clinically significant depressive symptoms, 2.2 times the odds to have a score consistent with syndromal major depression. Justin, and I won't do this justice, but just for a second, he asked a very interesting question. Well, what about, as Dr. Lin mentioned at the beginning, what about these hearing categories? What we say from 0 to 25 decibels of pure tone average, that's normal hearing. Well, what if we look within that normal hearing range? Is there, and look at variability from 0 to 25 decibels, or so all this being classically normal hearing, do we see any relationship with depression and cognition in this normal range? And he did. So even if you look here on the right, this blue line, here's this vertical line indicates the pure tone average of 25 decibels, which demarcates normal hearing to the left and hearing impairment to the right. And you see that, and here's CESD score on the y-axis. This line goes up, indicating that even within this classically normal hearing range, as your pure tone average departed from 0, basically, you had increased risk of depressive symptoms. So an interesting thing that we might talk more about, whether hearing capacities might be something more like blood pressure, where we'd really like the blood pressure, used to be that, 140 over 80 is high blood pressure, and we've been progressively decreasing that. And it could be the case that we really want people's hearing capacities to be just as good as they can be, because as they depart from excellent, we start to see risk for adverse psychiatric stuff. So as a result of some of this work, we felt pretty secure that, in fact, there is a link between hearing loss and late life depression. We started to want to drill down into what's the basis for this. And we're particularly interested in what are some brain mechanisms that might explain these links. And one thing we did was to try to look in a finer grained fashion at the relation between hearing loss and cognitive capacities. There's a lot of studies that just that look at hearing loss in relation to a clinical diagnosis of dementia, or look at kind of broad indices of cognition, but we really wanted to see what domain of cognition is predominantly affected by hearing loss. So we went back to the National Alzheimer's Coordinating Center database, and we looked at the relationship between hearing loss and performance across different cognitive domains. Here you can see all these charts. Interestingly to us, if you look here on the lower left, this is memory. There was no difference between the hearing loss and non-hearing loss patients on immediate or delayed memory performance, which we might have anticipated there'd be more of a difference here given the risk of hearing impairment for dementia. We didn't see much with attention or a little bit of starting with processing speed, but what we really started seeing was executive function deficits in patients with elevated pure tone, with clinician diagnosis of impaired hearing compared to those who did not. So here is a trail making test part B, which we control for processing speed, and this becomes a measure of executive functioning. We saw significantly decreased executive function, or this is the time to do this, so actually higher is worse here. So we see worse executive function in patients diagnosed with hearing loss compared to those without. A switching verbal fluency test, another measure of executive function, here higher is better, and we see a significantly lower performance in the hearing loss group. So this started to, and indeed performance on these tasks was quite linked to increased hazard of being diagnosed with dementia in this data set. So, but it is tough when we've tried to, as we've gotten our prospective studies online, and we've really looked to existing data sets to try to generate hypotheses and explore some of these. It's been a challenge because no study has all, there's no study answers all questions. And what we find is that, few studies were designed to provide data on objective hearing measures and comprehensive neurocognitive assessments and brain imaging. So in line with what Dr. Lin said at the beginning, what we really wanted to start doing is integrating hearing assessments into some of our ongoing studies. And I can just give you a flavor because we're at the beginning of doing this, but one of our ongoing studies is a multi-center collaboration whose principal investigator is Eric Lenz at Washington University, where we're doing the largest study for treatment-resistant depression ever done. And this will be as close as we can get to 1,500 individuals over 60 who are depressed and who have not responded to at least 2 antidepressant trials. And they enter a clinical trial where they're randomized to different treatment possibilities, and we try to see which options are going to work best. We received an add-on funding from the National Institutes of Health to try to understand this high-risk group. Treatment-resistant depression in older adults is a very high-risk group to go on to be diagnosed with dementia. So we got some add-on funding to try to look at the mechanisms in the brain and cognitively for how treatment-resistant depression is a risk factor for developing dementia. So this study, patients go through this clinical trial and they kind of concomitantly get enrolled into this longitudinal neuroimaging study where at baseline, they get some brain imaging of various sorts, they have cognitive testing, they come back at 6 months and then again at 2 years. What we did with the help of Dr. Lin and Nick Reed and the Cochlear Center was add shoebox audiometric assessments to the baseline 6-month and 24-month assessments. To really, here we were doing a study of depression and cognition in older adults without paying any attention to hearing capacity. So we got the opportunity to add these, and we're collecting data as patients move through this study and this longitudinal neuroimaging study. We're now collecting audiometric data on them. And I can just give you a brief taste of this. We're basically ready to analyze and report baseline correlations. We need to let the study progress further to get the 6-month and 24-month data, but we're getting ready to report baseline correlations between hearing capacities and neurocognitive and neuroimaging data. But just to give you a flavor of that, we're going to end up with 150 or 160 people. What we're seeing so far in this, in 117 people, who I have ready to show you right now, this is mean age about 69, 65, 35 women to men. They've got, mild to moderate depression. Just to give you a flavor, what about, treatment-resistant depressed patients? What do they look like hearing-wise? Well, almost half of them have a PTA over 25 or indicative of some form of hearing impairment. And only 25% of this 47.6% are currently getting any kind of treatment for their hearing loss, such as hearing aids. So again, we're documenting in this sample a kind of real unmet need for education and need for further treatment in this group. We also find tinnitus present in 35% of the sample. About 70+% of the hearing impaired patients with a pure tone average over 25 have tinnitus. And if we look at their cognitive profile so far, what we're seeing again is this is a R-bands is as a cognitive battery, and you can see here different cognitive domains. We don't see anything going on with really attention, memory. We see a little bit that patients with higher pure tone averages have lower visual constructional abilities. The DCEPS is an executive function battery, which we added on to our studies here to get better coverage of executive function. And this is where we see a lot of the deficits for these patients. So again, we seem to be, at least in these depressed hearing impaired patients, what we seem to be seeing is more of an impact on executive function compared to other cognitive domains. And I'll just say in passing, we also find that individuals who have tinnitus have significantly higher depression, and that their depression appears to be harder to treat, which is something that we're going to come back to and we hope to pay more attention to in our studies. But to As a result of some of these, kind of secondary data analyses, and now what we're doing with the OPTIMUM studies, we really started zooming in on executive function and cognitive control. So these are somewhat interchangeable concepts, but really what the executive functions are refer to the speed with which we process information, how we pay attention to this, but not that. We can direct our attention selectively to the things we care about, how we plan, how we can shift the rules for which we're following different tasks, how we can inhibit prepotent responses towards some other goal. And the neural network that subserves these various functions is spatially distributed in the brain, but prominently, as depicted here, includes nodes in the anterior cingulate cortex, this gyrus kind of in the medial portion of the brain right here, the dorsolateral prefrontal cortex, and the insular cortex. So this network seems to be important for cognitive control and executive functioning. We in the late life depression world are very focused on cognitive control and executive dysfunction because, as I mentioned earlier, over half of our patients have significant executive dysfunction. And it turns out to be one of the most important things in terms of predicting their ability and how they're going to respond to antidepressants. I'll just basically allude to this figure in the upper right here, where if you look at the disability associated with depression in people over 60, much of it is mediated by executive function. If you look here on the lower right, when we do research studies and when we do clinical trials for depression, we see significantly lower response to antidepressants in people who have cognitive control deficits or executive dysfunction. So we're in the depression world, we're very focused on executive functioning because it mediates a lot of the disability we see in our patients, and it's really our biggest prognostic factor for who's going to get better with antidepressants and who's not. As I've learned about it, cognitive control is an important capacity in the hearing world as well, that has been shown in multiple neuroimaging studies. And I just show here one on the left to provide an example. Whether you look at healthy people without any hearing deficits and have them do tasks where sound is garbled and degraded versus sound that is clear, we find that when you're really effortfully listening and attempting to decode this difficult kind of speech, that you engage a frontal cognitive control network involving the areas I just showed. And as hearing declines, we think that engagement of the cognitive control network supports effortful listening and is initially adaptive, but that a downside of it is that it sucks up a lot of cognitive resources and lowers cognitive reserve, that those processing functioning are not then able to be deployed to higher order processing. And also there may be excitotoxicity and more maladaptive remodeling over time. So we developed a model that we've written up, and now Katie's got an excellent review that will hopefully improve upon our one of a few years ago, where we hypothesize in the model we've been investigating that as age-related hearing loss progresses, we do see some deafferentation-induced atrophy of auditory cortex and associated regions, which itself could be linked to decreased executive functioning. And we see this engagement of the cognitive control network to support effortful listening, which basically takes away cognitive resources from other things that cognitive control is needed for, like emotion processing, regulating emotions. Emotion reactivity refers to just the bottom-up spontaneous emotional responses we have to stimulate. Regulation is a top-down modulation that we deploy to help us, feel better and navigate life. So our model is that these adverse structural neuroplastic changes and this compensatory engagement of the cognitive control network tend to impair executive function and emotion processing, leading to risk for major depressive disorder. So that's what we're going on to now they're still kind of coming down the pike, but we're investigating this model in some larger neuroimaging studies to try to lay this out. But in the interest of time, I'd like to just pivot towards some of our treatment studies, where, again, in keeping with that initial model, somebody comes in with late life depression and significant hearing loss. Why give them an antidepressant? why not fix their hearing and see if that might help their depression as well? It was that kind of non-rocket science idea that led us to begin investigating this. And this is my colleague, Anna Kim, who's been a close partner and integral with these studies. But just to give you an idea, the first thing we did was do a small pilot study with some Columbia funding, where we asked patients who were over 60 and had garden variety depression. They had a certain score and a certain threshold score on the Hamilton rating scale for depression. They had significant hearing loss and having pure tone average over 30. They'd not had prior hearing aid use. And they had the usual exclusions. And what we did was randomize them to whatever they're doing, whether it be they could get antidepressant medication or not, psychiatric treatment as usual. But what we did was randomize them to receive an active hearing aid fit to their prescription, or a sham hearing aid that didn't provide amplification. I felt it was important to have it. I come from some of my early work was actually on placebo effects and how to blind treatments and randomized control trials. So I thought it was important to try to blind the hearing aid condition, even though I figured it would be quite difficult. And we did pure tone audiometry in terms of the assessments. We measured hearing, their hearing-related disability, their speech discrimination. We did cognitive stuff. And basically in this initial just 13 subject study, we wanted to see, is this feasible? Can we do this? Are people going to comply? Are we able to blind hearing aid and sham? Is there any initial signal of effect? And what we saw in these hearing impaired depressed patients over 60 is that when we give you a hearing aid, this is the active here, and down here denotes decreased disability. The HHIE is a disability related to hearing measures. So as one would think, your hearing related disability decreased if we gave you an active hearing aid compared to a sham. Your depression level over the course of this 12-week study also decreased quite a bit compared to the people who got sham. And we saw some upticks on some of the cognitive domains, though wasn't as large an effect size. So we felt this will be this was promising. And but one thing we did have difficulty doing was the blinding. So as we asked people to guess, they were randomized to sham or a real hearing aid. We asked them to guess, are you getting sham or a real hearing aid? And pretty much everyone was able to guess. So we went back to the drawing board and tried to do a bigger and better study with some NIH funding. I say ish here because COVID derailed some of our enrollment and decreased the sample size that we ended up with, unfortunately. But what we did here was enroll a similar sample, patients over 60 with depression. Here we increased the severity of hearing loss a bit. They had to have a pure tone average between 50 and 80 decibels. We also added, we felt like we were most likely to help someone who is having trouble discriminating speech, and that might be more interfering with their social interactions. And so we added that on. We did our usual audiometric assessments, psychiatric assessments, we did neurocog testing, and we added some brain imaging, which I'll tell you a little bit about. We hoped to improve our sham procedures by giving a little bit of amplification with the sham hearing aid. So we again, and another thing in this study was everybody got antidepressants. So usual antidepressant care. And then we added on, we investigated the value added by a real hearing aid fit to your prescription or sham hearing aid, hypothesizing that we'd see more benefit on our outcomes if you got a hearing aid in addition to the psychiatric treatment as usual with an antidepressant. And we tried to provide a little bit of amplification to try to improve our blinding ability. Again, 12-week study, followed people up, we re-imaged them at endpoint, though many of my imaging data here will be based on the baseline because some various other trials and tribulations occurred, including the changing of our scanner at Columbia, which interfered, which happened midway through the study and interfered with some of the stuff. But just in the interest of time, I'll be brief. I'll be showing you data from 24 patients here. 13 were randomized to sham, 11 to the active hearing condition. They were aged pretty good for an antidepressant study. They were in their early to mid 70s, fairly well educated. They had mild to moderate depression. Both here, the Hamilton is a rater administered measure. The IDS is a self-report measure of depression. They had an average pure tone average in the mild to moderate range. They had fairly good speech discrimination, but significant disability associated with their hearing impairment. And we could talk more about physical functioning perhaps later. The only thing I'll point out here is, again, you see with the so the R bands, this is cognitive testing. Here's memory, immediate and delayed, attention, language. The NIH toolbox flanker is an executive function measure. All of these tasks are kind of normed to have a mean of 100. And on the NIH toolbox, at least, the standard deviation of 15. So if you're a standard deviation below 100, you have significant difficulty in that area compared to other people your same age. And you see most of these scores are around 100 or better, except for flanker. And visual spatial was a bit lower too. But the lowest scores we saw were for executive functioning, which again kind of went along with what we were seeing earlier in terms of, at least in our hearing impaired depressed patients, the predominant cognitive signature of hearing impairment tended to be executive dysfunction and cognitive control deficits versus memory or other aspects of cognition. So what we saw in terms of depression over this 12-week study was a bit more improvement. Again, small numbers, so just giving you a flavor here, a bit more improvement in depression. Here I'm showing the quantity of depression improvement. So there was 2 points more depression improvement in the hearing aid group compared to the sham. If you aggregate data across our 2 pilot studies, which had very similar methodology, we do see a bit of improvement associated. These are depressive symptoms getting better to a greater degree in the hearing aid group compared to the sham. About 4-point Hamilton difference, which 3 to 4 points on the Hamilton scale is typically what we see as comparing drug to placebo. All these guys are on drug, really. So the difference of 3.8 Hamilton points would be, considered clinically significant here. Now, what about cognition? Here we have the flanker, and here test, and up is better. And we have people who got active hearing aids in this dotted blue line, and the black is people who got the sham hearing aids. And we measured them pre-treatment and post-treatment. And we saw improvement, actually, a fair, moderate effect size of improvement on people who got hearing aids on the flanker test. This was, I apologize for the busyness over here, but we didn't see the same degree of improvement on some of these other, on any of the other hearing tests, really. We did see some physical functioning improvement, which we like to see. This is a short physical performance battery, which is an NIA developed measure, and knowing that hearing loss can be associated with balance and gait problems, we were hoping that we might have a positive impact on gait and physical functioning with hearing aids, which is also related to depression, I should say. But just again, what we're seeing so far in the data is a predominant impact of improvement in executive function as compared to some of the other cognitive domains. People were very compliant. We required people to use the hearing aids for at least 8 hours a day. And everybody did, with no difference between groups, even though, again, we had trouble with blinding. The people who were assigned to and received active hearing aids were effectively blinded, but the sham participants guessed they were getting sham. So blinding was, again, an issue in this study. And in our subsequent applications, I think we've essentially decided we might not be able to use the sham condition, and we're using other comparison groups. But I know we're running short on time, and I apologize, but I want to give you a flavor of some of the brain imaging. Consistent with what Dr. Lin and some of his studies and other people have shown, we do see that when you look at, this is 14 of our participants who got T1 weighted or structural brain imaging at baseline. And then we looked at the, irrespective of what treatment you ended up getting, was there any association between the brain structure in auditory areas and hearing loss documented through pure tone average or speech discrimination score. And what we saw is that a thinner left auditory cortex was significantly associated with higher pure tone average values and lower speech discrimination. So this seemed to be that hearing loss was associated with thinning of the primary auditory cortex. When we look at some of the DTI data, actually the DTI, diffusion tensor imaging, looks at the integrity of white matter tracts in the brain. It's a different MRI sequence that utilizes kind of the directionality of water movement along white matter tracts. And what we saw come up on both sides, so fractional anisotropy, the higher this is, the more intact your white matter tract, and radial diffusivity, the higher that is, the worse it is for your white matter integrity. We see the SLF, the superior longitudinal fasciculus, which carries auditory information, but is also the real canonical frontostriatal white matter tract that also supports cognitive control and executive function in our late life depression studies. Interestingly, better integrity of the SLF on both left and right was associated with higher speech discrimination ability. Just to give you a flavor here in some of our functional data, we use task-based fMRI in order to evaluate the brain underpinnings of executive functioning in our patients. And here on the left, you see the Simon task. So the Simon task is a task in which you see an arrow appear on the computer, and you're instructed to press a button according to which direction the arrow is pointing. So if it's this arrow here, you press right. If it's left, you press left. So when a right pointing arrow is displayed on the right side of your computer screen, we're all a bit faster than we are if a right pointing arrow is presented on the left side of our screen, and vice versa. So what we can do to get a sense of this response, we have a tendency to want to press left if we see an arrow on this side, no matter what direction it's pointing. So this is a measure of response inhibition, where I inhibit that initial response to press left and pay attention to the directions and press right. So what we see when we do this task in our patients in this study is the task works how it's supposed to work, that people are slower on these incongruent trials compared to the congruent trials, and they're less accurate. And that if you do the contrast between incongruent and congruent trials, you see activation of this cognitive control network, which, as I described to you earlier, includes the insular cortex and the anterior cingulate. The more, what we found in our study so far is that the more people are able to activate this cognitive control network on this task, the activation in these nodes of the cognitive control network on this task were correlated significantly with improved speech discrimination. So again, seem to be pointing to the importance of activating this cognitive control network for effortful speech discrimination. This is like microscopic number of patients. My colleagues would look askance at me for even showing this, but I just thought it was kind of interesting, and hopefully we'll build up more numbers. If you look at activation on the incongruent congruent contrast in these nodes, in the sham and if you look at the change in the activation in these nodes in the cognitive control network from pre to post study, so baseline and 12 weeks, and either you get a sham or a hearing aid, the activation, just the directionality is totally different between the two groups, that we see decreased activation, possibly, if we wanted to speculate, be associated with the decreasingly effortful, the decreased need to engage this cognitive control network to support effortful listening in people who got hearing aids and are now able to hear better. So hopefully that gives you a bit of a sweep through that. Basically, to summarize, in everything we've looked at so far, we see a robust association between hearing loss and depression. It doesn't matter what kind of sample we're looking at, whether it's no hearing loss or mild hearing loss or severe. We see this link between hearing loss and depression. In our data, we see that the neurocognitive profile of hearing loss really prominently indicates cognitive control deficits and executive dysfunction with sparing of other cognitive functions. And that in this very, very small study, at least so far, it looks like perhaps treating hearing loss may be helpful for both depression and cognition, and may help reverse some of the neural activation differences are associated with hearing loss in our patients. So it remains to be substantiated in further studies. So thank you to everyone, including my colleagues at Columbia, of course, and Katie Brewster, who's done a lot of this work, and Justin Golub, but also Dr. Lind, who has really been a mentor and friend as I've gotten into this world, and Nick Reed, who helped us very much getting the shoebox measures up and running for our OPTIMUM study. So thank you very much.
Bret, I want to be the first to thank you for, honestly, really an incredible talk. I mean, what I love about it, I think I may appreciate, is that sort of the idea of bedside to bench, back to bedside again, metaphorically, right? Using clinical experience as a guide, the science and neurobiology and understanding the mechanism, and going back again with intervention. So thank you so much. I want to just, I want to pose the questions now that have come through the chat right now, at least, and we only have a few minutes remaining. So I'll just say, if anyone has any questions, please feel free to put them in the chat right now. But the first question comes from Jean Tyan, and she asks, to your knowledge, does the relationship between hearing loss, depression, and dementia differ by race, ethnicity, or social determinants?
No. To my knowledge, no. We did look at that in our NAC, National Alzheimer's Coordinating Center data, and we do see differences in the constituent, category, whether hearing loss categories and depression and dementia categories based on race and ethnicity. But if I'm remembering correctly, and Katie might be able to help me out here, but the race and ethnicity did not necessarily moderate the relationship between those variables that we observed. That's just one data set that we've looked at so far.
Thanks. We have a second question here from John Swen, and he says, Dr. Rutherford, great presentation. I'm curious whether your team also collected baseline information about socioeconomic status, in particular the role of financial strain, which may or may not have impacted mood depressive symptoms, physical function, physical activity, as well as degree of social integration or loneliness. Probably, I guess, assuming it's probably covariates in your analyses.
Yes. All of we have data on pretty much, we don't have we have data on employment and income and stuff like that. But and I should say one thing that got really short shrift in this presentation, just by necessity, was we're very interested in social support, social engagement, social isolation, and loneliness as potential moderators and mediators of the hearing depression relationship. And so we do measure all of those things in some ways, and not all of them made it into this R21 study that I was describing, but they are very much a part of what we're looking at moving forward. So we expect that, the social isolation and loneliness may be kind of parallel and interacting pathways along with these brain mechanisms, as well as tinnitus, which we need to take a deeper dive into in our studies. So we do have, and I can be happy to talk offline or whatever about some of the data we have on those things.
So I want to be mindful of time and everyone else's time, I would say. It's 1:15 p.m. right now. This is the conclusion of our webinar. I want to make a couple of thanks toward the very end, though. First and foremost, to Dr. Rutherford, really just an incredible presentation. I'm so sorry we couldn't have you in person, but maybe we'll get you back here next year, actually. So we are looking forward to that. I also want to thank everyone, all the attendees. I think we've had over 50 to 100 people attend all these different seminars and lightning rounds over the last week, which is again our first foray to making the Cochlear Center Research Day into a virtual week. Hopefully we will never have to do this again. And then more importantly, a big thanks to Mindy Pitt, Shannon Smith, and Molly Sheehan, and Jamie Trumbo, who were really the backbone of all the administrative efforts that made this week possible. So thank you again, absolutely, to everyone. Please feel free to reach out to either the Cochlear Center, we can pass on questions to Dr. Rutherford himself, or with any questions or comments about Research Week. Any feedback would be wonderful as well as we think about planning for future events. This will be a wrap for now. For the trainees in the audience at the Cochlear Center, please stay aboard to the next Zoom session where you'll have a chance to interact with Dr. Rutherford directly. But to everyone else, thank you again for joining us. We will have a chance to post many of these things virtually as well, so please check back on the website. Thank you again, everybody.